I'd like to welcome everyone to the AO Journal Club on femoral shaft fractures. I'd like to thank our moderators, Dr. Carolyn Tuga and Michael Talarico, and I'd also like to thank our staff, Dr. Lawrence Bone, Dr. Ross Layton, Dr. Robert Brumbach. Thank you for participating and providing some insight on your research on femoral shaft fractures and kind of where things were and where they're headed. This is a disclosure page. There's a few disclosures listed here. They won't, this is for educational purposes only. And if there's any issues, please see this page. But as stated, this is for everyone's education. As far as Zoom etiquette for this session, your microphones and your videos are turned off. If you have questions, please submit your questions in the question and answer section. The moderators will be moderating that or monitoring that. And once we're through with the interviews, then we'll ask the faculty the questions that were listed, and feel free to participate and get your questions answered. As far as the agenda, we're currently in the introduction. We'll have a recorded interview with Dr. Bone regarding delayed versus early stabilization of femur fractures. Next will be Dr. Brumbach's paper on immediate weight bearing of comminuted femoral shaft fractures. And then third will be reamed versus unreamed nails in a Canadian series with Dr. Layton. Once these are done, as stated, we'll review your questions if there's any submitted. If not, we'll ask our own questions and kind of question the staff and ask them their thoughts on the current state of affairs. And then we'll wrap up about 9 o'clock Eastern. The learning objectives are to review current and classic journal articles and how they pertain to this particular study and how they were conducted, and then best practices based on our current scientific evidence. So without further ado, we'll start with the first interview. Dr. Bone, thanks for joining us.
You're welcome.
Go through your experience dealing with femur fractures and how things were dealt with before your paper came out.
The paper came out in '89, and we did the study in Dallas between 1985 and '86. But I started getting interested in femur fractures, and especially femur fractures in the multiply injured patient in the early '70s, when I was a general surgical resident in Buffalo, New York, and was mentored by John Border. Dr. Border was a general surgeon who treated the multiply injured patient, but he also managed fractures as the general surgical department alternated fracture call with the orthopedic department. In the 70s, the standard management of a femur fracture was to put them in skuldal traction. Standard time was about 7 to 10 days, because they felt that if they waited 7 to 10 days, they felt that they healed quicker. So everybody with a femur fracture, whether it was isolated or multiple trauma, got skuldal traction. There was a reasonably high incidence of what we called fat emboli syndrome. There were some papers that came out of Europe in the mid-70s showing that if you did early stabilization of the femur fracture in a multiply injured patient, you could significantly reduce the fat emboli syndrome complication. The most famous one was from Helsinki, Finland, by a doctor named Riska, who reduced the fat emboli complication from 22% to 2.5% by doing early stabilization. But Dr. Border believed in it, and we started doing early stabilization in the mid to late '70s. This was not standard treatment, however, and when I went to Dallas to do an orthopedic residency in 1983, Ken Johnson was an attending, did a fellowship with Ted Hansen at Harborview. Ted was the only other person that I know of in the '70s that was treating the multiply injured patient with femur fractures in an early stabilization. Ted and John hadn't connected yet, but they believed in the same principle. The study came about when Ken asked me to sit on a panel of a grand rounds in the general surgical department on fat embolized syndrome. During that panel, I told them that in Buffalo, we treated fractures, femur fractures early and significantly reduced the pulmonary complications. They thought I was crazy. They absolutely didn't believe that femur fractures or that orthopedic injuries had anything to do with the complications of the multiply injured patient. General surgical departments were, quote, the captains of the ship, and they dictated to orthopedic departments when they could treat the fractures. So when I sat with Ken after that symposium, we decided we needed to do a prospective and randomized study that early stabilization made a difference in the multiply injured patient. What we worried about, however, is that because of our bias, that early stabilization was important, we could be criticized. So we asked John Weigel, who was a young trauma surgeon in the general surgical department, to be part of the study. He didn't believe femur fractures were important to be treated early. And so he could be our control. I have to tell you about the randomization because randomization wasn't, there weren't very many orthopedic papers out there that did prospective randomized studies in 1985. Yeah. And I wasn't really sure how to randomize them. So I took pieces of paper and I wrote early and late on each one. I mean, individually, and I wrote 100 of those out and I put them in a shoebox and shuffled them up and then pulled them out one at a time, put them in an envelope that were labeled 1 to 100 and tacked them on the bulletin board in the emergency room. And that was my randomization. It might not have been scientific by today's standard, but it was definitely randomized.
So this is kind of a classic. We have an idea, we think this works, and now we have to prove it, and that's where this study came from.
Right. There was retrospective evidence coming out of Europe that early stabilization was important. And we knew the difference because we had lived the difference. I can give you an example. When I was a general surgical resident in Buffalo with John Border, we alternated fracture call every other night with the orthopedic department. We were doing early stabilization. We were plating femurs in those days as per the AO philosophy. And the orthopedic department was putting them in traction, which was standard care. And in the emergency room, John could document the difference between their patients and our patients. So we knew it made a difference, but we had to show the world that it made a difference.
And I've seen in frequent, in like review books that this article, they cite your article saying this changed people's minds, this changed people's mindsets.
It did. At the time, it was the best we could do. And it did. It absolutely changed the way orthopedic injuries were managed. I've taught all over the world for 30 years. I smile on my face when I remember back giving a course in polytrauma in Switzerland. And one of the faculty was a orthopedic surgeon from Britain. And he told me that when that paper came out, he used to put it in his back pocket and walk around. And every time a polytrauma patient came to the emergency room, he would show that paper to the general surgeon and the anesthesiologist and say, see, we got to do this. It was the proof. It was the proof people needed, yeah. Especially if there were doubters in their hospitals, and really there were.
After this is done, right? How did it change? How did you see it change? Did the orthopedic surgeon now become the decision maker as far as stabilization, or was the general surgeon in charge still?
The general surgeons are always in charge, but we became much more of a collaborative team. Orthopedists now had the evidence and developed a protocol for managing the multiply injured patient. Vast majority of polytrauma patients could have their femur fractures treated, stabilized safely. That's what we wanted to stress. One of the important parts of the Buffalo experience was that because we were the orthopedic surgeons as well as the general surgeons, we didn't have to fight. We just went in and did what we felt was the right way of managing it, and then showed the results.
Based on this, something you mentioned is, if someone's too sick initially, but ongoing resuscitation doesn't mean you got to wait another 24 hours until their labs improve, and then
Right.
still being aggressive, getting them fixed early.
Right. An excellent question, because that's the way we managed them in Buffalo. You do not want to take to nail that femur in a patient who's not stable. But the idea that they're not stable now, but 6 hours from now they can be stable, and you can go ahead and nail them. Time period around 48 to 72 hours, that it is not a good time. But if you can get them within the first 24 hours,
Yeah.
Even if it's not immediate, even if they've been coagulopathic and I don't know if I coined the word, but I use it, it's resuscitate them. The general surgeons take them and they do their surgery, and now they need resuscitation again as if they were freshly injured. And then you get their parameters controlled and stabilized, and then you can go and take them back. And we've done that routinely. The concept of too sick has changed. We can make them better. The old days was, oh, they're too sick, we got to wait and until they get better, but they never got better. They were put in skeletal traction. They were in this forced supine position. ARDS developed, and we never got to them because they died. Yeah. Too sick was a bad concept. They're not ready, but we can make them ready, and do them at an appropriate time. The concept of damage control, which came out in the early 90s out of Hanover, Germany, that's a whole different story. And I think I had to fight back on that concept, because their idea was, well, they're too sick, we're just going to put them in we're just going to put an X fix on them. That was certainly better than skeletal traction. Still forced them to into a forced supine position that we know is damaging. But there is a place for damage control. There certainly are patients that come in so sick, and it's better to stabilize them with X fixes and get them, give them the ability to be mobilized than to put them in skeletal traction. I fought against damage control because I was afraid when it came out that it was going to be an excuse for the orthopedic surgeon to not operate. I gave a John Border talk at the OTA some years ago, and I pushed very hard against that, because it's not your convenience, it's what's best for the patient. In 30 years of managing multiply injured patients, I can only count on one hand how many times I had to do damage control. Many of these polytrauma patients in those days were not adequately resuscitated, and so they never got stable enough to be stabilized. In today's world, if we can't get a patient stable, then they're really in trouble.
This idea comes out of damage control, and then, like you said, it gets kind of propagated to the point where we'll just put them in an X fix, and then you can ignore them. It's a continuum in finding that window when they're stable.
Right, and a good point is that all those lab values that we get are only a marker in that moment that they're going to change, and if you're changing them in a positive fashion, then it will become a time when, okay, they're good, let's go, let's stabilize them and do what is best for the patient at this time. If you never get to that point, then damage control is the next best option.
So one last point, we'll wrap it up with this, but so we have a stable window. The patient, the labs have trended toward in the right direction. Can you kind of give your approach if they're critically injured?
Right. The approach is with the least amount of blood loss that you can. So you only reamed to get a nail in that will stabilize them. It's so much better than the old days where we had to ream to 18 to get a nail to be stable enough.
Wow.
Yeah, wow is right. But
Wow.
That's what we did. We reamed to 18 in order to get enough purchase on the nail in the medullary canal above and below the fracture site to control rotation. So yeah, it's and the concept of retrograde nails is for the femur was a great addition to our armamentarium because so many of those distal thirds could much more quickly be nailed. They could be nailed in supine position, which we can even now with the antegrade. But yeah, you don't want to waste time, and you don't want to bleed them any more than they've already bled. I would like to interject one thing here that I don't think got enough importance during the study. We randomized every femur, not just the polytrauma patients. So that an isolated femur fracture would be put in traction if they were randomized to late. And I want to remind everyone that late for our study was 72 hours. It was not 10 days.
Right.
Ken and I both knew that 10-day mark, we might have patients die on us. And so we wanted to make it long enough to make a difference, but not long enough to be harmful to the patient. We didn't lose any patients. Nobody died because we waited, but a lot of them got significant pulmonary complications because of the traction. But what I wanted to say is the isolated femur fracture, we followed their blood gases, and I can't remember now how often, but frequently. And if we saw young, healthy male patients with an isolated femur fracture drop their PO2 sets from 90 to 60 routinely just by being in traction in bed. And if you were to put that on top of a pulmonary contusion or multiple rib fractures, it doesn't take too much to extrapolate. Yeah, that's why they get ARDS. That position was so detrimental to your capacity to oxygenate that it was a really bad concept.
All right, we'll go on to the next video.
Can I help?
I'm just finding it here.
Okay.
So if you could just, you mentioned earlier that this was, you view these papers kind of as all together, these studies together. Can you put that in context for me on what this and its sister or brother papers meant to you, or what the impetus was for these?
Sure. Back in the 90s, we had made the shift from just nailing femurs to static locking femurs. There was a concern back originally that static locking would be too rigid and the femurs wouldn't heal. Now we can static lock everything. At least I believe that's the standard of care. But we went through a series of nails with different types of nails that were more dynamic in nature, and we saw a shortening in failures. So everything was being statically locked. And the next step was, well, what can you do with the multi-trauma patient that has this injury and this fixation in it? In other words, we had people who had injuries of bilateral lower extremities who couldn't get out of bed if you weren't going to let them weight bear at all. So the more that we did static interlocking, and yes, we were using 2 screws all the time back then. But the more that we did static interlocking, we saw that there was a select group of patients who needed to use that leg for mobility early on. And sometimes people have misconstrued this in that the patients that get a femoral nail that's static interlocked are going to just dance down the hall like they don't have an injury. They don't. They have muscle injury and periosteal pain and fracture and so forth. So they don't go crazy, but allowing them to weight bear early gets them up and gets all the positive things of mobilization of the patient, not just cost, but out of the hospital earlier. But I believe it's good for the patient anyway. So we wanted to see if static interlocking led to healing, or did it deter healing? And found it did not. And then we went ahead to say, well, can we go ahead and push the envelope and let these people weight bear?
Okay. So what was being done at the institution, is it what you described in the article, or was this considered even aggressive, or was there pushback among your partners versus the greater orthopedic community in the United States and North America?
I think we were actually, in some ways, we used for a while a thing called a Brooker-Wills nail, which had these fins that came out. That we used that probably too long, and that did allow some shortening. So we went to the static interlocking, and we're very happy with the amount of callus and early healing. I think in terms of weight bearing, most people did not do that, and I think that this was at that time when even femoral nails and interlocking nails were just becoming a big community thing, where a lot of these people were in trauma centers, and so they were being looked at people like us at Shock Trauma, whereas the community, I don't think, would have been out there allowing their femoral fractures to weight bear. And so in the patient with an isolated femur that maybe didn't make it to Shock Trauma in Baltimore, I think that patient was put on crutches and probably put toe touch or foot flat non-weight bearing by the community. I think that the takeaway, in my estimation, was that, oh, just go ahead and let them walk. And I think that that's not reality. I think that when we said you can weight bear these after injury, it doesn't affect healing, and your loss of fixation is really very, very unusual to occur. I think that it's like reading the headline and not reading the article. I'm not sure we even understood it. We were looking to really change the way the postoperative care was given. And so we kind of let that go on a little bit, where people say they could weight bear. But anybody who's treated femoral fracture, people with femoral fractures, knows, again, they're not walking down the hall with a cane the next day. They hurt, they just are not, their muscle simply can't hold them up. It's been torn. Think about what happens every fracture you open up to do an open reduction. You look at that muscle and you go, well, it's obviously been injured. It's not easy for them. So I think the reality was that these people were able to protective weight bear and maybe help use their legs, some cases just for stand pivot transfers to get out of a chair, sometimes to be able to shuffle across the room to the bathroom. It was not as if these people were riding exercise bikes with full knee range of motion, getting their strength back at 3 weeks out. They just aren't. It's just too big an injury.
No, that's good. In terms of the biomechanics portion of the study, do you think if you redid this today, what materials would you choose to use, and how would you do it differently, if so?
Oh, that's a great question. We were using back then stainless steel devices, and obviously most of the devices now are titanium based. So I would certainly do that differently. And the other thing is, now that I've had experience with this over time, what I found was, and it's not really in the paper, is that there's an alpha screw. One of the 2 distal interlocking screws becomes the one that really bears most of the weight. You think that you've got them both across the distal femur, and they're both through the nail, that they're sharing weight equally just because they kind of looks the same. They're not. And one will break before the other every time. You hardly ever see two break at once. I can't imagine that I've seen that very often in my life. And that's hundreds and hundreds and hundreds of femoral fractures that we looked at. So I would probably try to devise this study to see, would I do it with just one screw? Yeah, I would. And would I do it with 2 screw configurations to try to figure out how you get that alpha screw and how you get the non-alpha screw. The alpha screw is, what I mean by that is that's the one that's really doing the resistance to shortening. That's the one bearing the weight through the nail screw bone construct. That was one of the things I think I took away from it, that obviously it was a conclusion that was well after the paper was done.
Okay. Synthetic femurs, were those in existence at that point, or would you still use a similar substance to pop the implants in now?
We had long discussions about that. We had, at the University of Maryland, we had a huge cadaver availability. So we could have done cadaver femurs, would have really upped the expense, but it also would have thrown in the variable of bone density. And then we would have had to get bone densities on everyone. So this is really a test of the screws. We both have seen screws that windshield wiper back and forth a little bit. Obviously, that's a screw bone interface failure versus a rod screw failure. We were concentrating on the rod screw failure, even though I think the other exists and the other is important. And I would do something different to try to bring that variable into the study. But in the end, even though we tested the entire nail, we really turned out we were testing the 2 distal inner screws because the proximal screw didn't break. And that's a whole nother, you asked me for things I learned. The proximal screw in all of these nails was a diagonal greater trochanter to lesser trochanter, what we called 1st generation locking screw. That's hardly ever used today. Nobody ever uses it. And why those transverse screws are more susceptible to breakage than that a single oblique proximal screw is an interesting phenomenon. When you take a screw and you have a certain core diameter of it and you load it at 90 degrees, that's obviously different than if you take the same diameter screw, you turn it 45 degrees, the core diameter in line with the nail is actually greater because you've turned something round made it an oval. And you don't see proximal interlocking screws break anywhere near as much as you did the distal ones with this early 1st generation construct, but now you do. So it is a classic thing that you try to do some research and you start asking more questions than you've answered. So I look at it that way, but we don't use those screws anymore. So it's probably a moot point at this time.
Well,
kind of turn your question around a little bit.
Sure.
If the femur was intact to below the lesser trochanter to within a centimeter or so of the true isthmus, which is, it depends on, in different people, it's a different length there. But we would just use a single proximal interlocking screw. We were perfectly happy with that. Once you get up to the lesser trochanter and the endosteal diameter gets larger, then you have more of a problem with the nail can kind of swing back and forth in that canal like a pendulum on a clock, and you get varus of the proximal femur, and you're dealing with subtroch fractures in that view. And that's a different animal, and that was not tested here.
Okay.
I know that maybe I should ask you if.
And for me, when you had this type of fracture where you weren't going to get any type of fit, where would you stop your size increasing, and what were you trying to get to, or what was your thought process in practice for clinical application of this?
Well, that's a great question. First of all, with the devices we had then, the 10 millimeter nails had smaller diameter screws, and therefore they were weaker in terms of repetitive stress. Once you got to the 12 millimeter nails in the nails that we tested, the screws were the same diameter as whether you put in a 13 or a 15 millimeter nail. And I think that reaming has become a little bit less of in my view, a little bit less of a big deal in terms of fit. I don't think it's an interference fit because you over ream these enough that, because the nails are stiff, you over ream them enough that it doesn't really matter whether you put a 12 or a 13 or 14 in maybe in terms of nail breakage in the laboratory, and I mean nail breakage, not screw breakage, but nail breakage in the laboratory, that would matter. But in real life, I don't think we see our femoral nails breaking for isthmal, for shaft fractures very often. We see that in subtrocks because of the higher, compressive distractive forces there. But I think that it's not a matter of fit. I think that that's why some people only put in 12s. Now, the reason I would go bigger at times on a patient, not in this study, but on the patient, is because the bigger you are, the better aligned the fracture can be. The nail can't move. If you have an elderly lady with a massive endosteal canal, having a 15 in there does line it up better than having a 12. It does, but I don't think that mechanically it makes a big difference on whether the fracture is going to remain intact through fracture healing. I don't think that makes a difference.
Okay. Is there anybody you think was left out that should have been brought in, or vice versa?
A good question. I think that I would have done it differently, because I think back then in the 90s, we were just trying to kill science with numbers. We were trying to just collect as many sequential ones as we could, and I think that that's not a very good way to do science, and I don't think your residents should see that as a good way to do science. I think that it would be better to do a study that is has much more emphasis on all the variables, some of them that you just mentioned, and maybe even put a pressure in their shoe so you actually determine how much weight bearing they're doing. I mean, we don't even know that. We don't know that. And so I think that it could have been done much better. I think I look back on some of the studies we did, and basically because we were a high volume trauma center, we could just rack up numbers. It's like putting cars in a parking lot and trying to sell them. The more you got, the more people come in and look at them. Well, that's not really the best way to do science. You need a method that will try to differentiate between different variables, and we weren't really trying.
The top two thoughts about when someone asks you about this or about this topic?
I think I'm happy that I thought we kind of advanced treatment a little bit, and I look back at that kind of like we did something pretty good there. I don't think we necessarily proved it as well scientifically as we did, and I think that you then go on to the next question, and I just look at it. I'm not one who looks back and goes, kind of in an almost a sentimental way. No. We pushed it to that, and heck, we weren't even doing retrograde femoral nails back then. We had lots of things to open, lots of questions to answer, and I would just say, this is what we found. I think clinically it's been proven to be true, and let's move on to the next question.
All right, on to the last interview.
Unreamed intramedullary nailing of the femur, comparison of the rate of ARDS in multiply injured patients. With me, I have Dr. Ross Layton, one of the senior authors on the paper. Hi, Dr. Layton.
Hello.
Welcome.
Thanks for having me. Thank you very much. Appreciate being here.
So I will quickly just summarize for the listeners that this was a randomized control trial, and roughly 300 patients with injury severity scores of greater than 18 were recruited and assigned to receive either a reamed or an unreamed intramedullary femoral nail within 24 hours of admission.
Right.
The primary outcome was basically the development or not of ARDS. And the key finding was really that there was no difference between the two groups.
Yeah.
So Dr. Layton, these results were in contrast to some other studies that were previously published around that time or prior to it. Can you please summarize for us what those studies were and the impetus for this randomized control trial?
Yeah, well, to put it in perspective, we first started a trial to look at reamed versus unreamed nailing. So that was the first study we did with the cost group, and that had about 200 patients in it, 230 patients. And what we showed very definitively, and it's been repeated over and over, is that minimally reamed nails are way better than reamed nails than unreamed nails as far as complications are concerned. So you can make a case for either one, but if you look at a bunch of patients and look at them, then the complication rate of the smaller unreamed nails is greater. So from that group, we decided that we'd see if we could make any suggestions about ARDS, and it was too small a group, so we increased the group size to 300 and some, as you pointed out. Now at that time, there's a lot of controversy coming mostly out of Germany with Pape's paper and things saying that if you had an associated lung injury or multiple traumatized patient, that damage control surgery was better, that was kind of thing, or unreamed nails were better than reamed nails, so anything that didn't affect the intermedullary canal as much would be better for the patient. And our literature in North America just didn't match that, so we couldn't match that. So we decided that we would try to see whether in this group we had of 200, if we increased it to 300 or 400 patients, would it show a difference in the ARDS groups? That was the impetus for the paper. I think the real controversy seems to be Europe to North America, and I think that's been looked at many times. And it's not to say Europe is wrong. I think a lot comes down to transfer and delay and things of when they get people. Like I think that ours are obtained fairly quickly, and I think sometimes theirs are delayed just getting to the centers that they're at. So it's it really comes down to choices, So
Do you think that was one of the main differences between the North American and the German or the Pepe article versus the North American articles? Why was there such a higher ARDS rate?
Yeah, I don't, we looked at that multi different ways and we couldn't really show why. I think they really focused on damage control and they thought that was a big thing. And I think it really did bring it to the forefront, and that was their goal. And I think the problem was it was taken like everything and applied to all the patients, that we had to do damage control on everybody, which was, we were trying to say, don't do that, right? So I think there was a little bit of pushback from North America to say, we don't want to do external fixators on everybody. So which ones do we have to do it on? So it kind of fine tuned it a bit. I think when the dust all cleared, both groups agreed that that's probably right. So I think the groups really have settled into a pretty similar pattern when you talk to them now. They're not doing as much damage control, and we're not doing as much, immediate IM nail. So I think we're both thinking a little bit more about the other guy's study, and we've got sort of made a nice compromise, I think, that's helped our patients.
Okay. And on that note, any other feedback or reviews or critiques that this paper received at the time of publication or since?
No, this one didn't. Well, this one didn't receive as much as what I say. Pape stole the show on that one. He got most of the reviews on that. But I think our paper, the initial paper, got a lot of feedback on, because people really liked unreamed nails, and we were saying they weren't that good. And it was repeated over and over, and it was showing that unreamed nails were just not as good as the reamed nails. So that really was a change in practice that people doing them now don't really get, because they just always done reamed nails, not a big deal. So it just seems. So I think that was the change in practice. The ARDS picture was really hard to show because you needed so many patients to indicate it. So I don't think we had a real show-stopping paper in that one, but I think we had enough to say that we could do more papers to prove that you didn't have to do damage control all the time. So that was good.
Great.
Opened the door for other studies. Yeah.
And how was it executed as part of the COTS group?
Yeah, well, in the COTS group, we come up with a plan, as you know, and then we prepared for the group. There's 16 academic centers in the group, plus community centers. And then we decide on a protocol and then reach out to people to see who want to be involved. And normally when you finish up, although 8 or 10 sites start out, usually about 6 sites finish it and carry out the randomized trial. But it's a randomized, so you pick it out and it's completely randomized. When you enter the inclusion criteria, then you go to one group or the other, and that's carried out until we feel that we've reached the end of the study, either by nature of we've completed what we think we would find, or it gets to a point where if you went any further, you'd have to recruit so many patients it would be ridiculous to try and keep on going. So.
And I mentioned one of the key findings, but can you tell us in your own words, what was the main takeaway from this study?
Yeah, so our hypothesis was that, if we didn't do as much damage to the intermedullary canal, that the unreamed nail, although it had a higher complication rate in the majority of patients, we thought maybe that the unreamed nail might be be safer in that group that developed ARDS. And as it turned out, it wasn't. So minimally reamed nails were just as safe as unreamed nails, and they had the positive value of having less complications as they went out. So you could get a bigger screw size, and then mostly you could go from a 4mm screw to a 5mm locking screw, and that made a big difference as far as breakage was concerned. So our hypothesis did not prove correct in our group, and then when we looked at it, we thought you'd have to get about 30,000 patients into it to actually show a difference. So our percentage, and I think Bob O'Toole told the same thing, is only about a 2% or 1% ARDS rate. So when you only have a 2% difference in your groups, there's got to be an astronomical number of patients to show a big difference. So no one's really attempted that study. And I think that's appropriate given the
Right.
numbers. Yeah.
And then do you think any improvements or modifications you would have made to the study originally or make to any spin-off studies that might follow from it? And
Yeah.
do you think further study is required on this question?
I think it's going to would take a lot of patients to do this. As we mentioned in our group, we looked at the percentages, and Bob O'Toole has the same numbers, 2% or 1.5%. With that size of difference, you're really looking at thousands of patients to show a big difference. So I'm not sure it's worth the cost of the study to determine when the incidence is so low and seems to be about the same. I think that you're probably not worthwhile for ARDS. I think we want to do something in nails to see what's a better nail. That would be a good study to do, because we always shown is that reamed is better than unreamed. We haven't shown what style reaming, what kind of nail, a tan fan versus which entry point's the best, whether you put 1 screw, 2 screws. There's a lot of things there that I think I'd look at for sure. But I don't think ARDS would be a big look from my standpoint. I think they're really sick. They go to damage control. I think if they're otherwise well and you get them within 24 hours, the majority can be treated with a minimally reamed nail. Yeah. And the one thing we did around the same time, we looked at mechanically looking at pressures. And one of these things that came up in our pressure readouts was that, the first thing that goes down the canal gives you the highest pressure. So if you put an unreamed nail down, you actually get the same pressures in a patient's femur as you do putting a reamed nail down. So the first nail that goes down there, whether you put a 9mm reamer or an 8mm reamer, it throws up the highest pressures. So you're really not saving anything. If you put an unreamed nail down, you actually have the same pressures as a reamed nail, and it sustains itself a bit longer. So the curve kind of looks a little less peaked. It sort of goes up and then goes high and goes long, goes through, but the peak pressures are the same. So that was kind of surprising, but made sense then. If you
Right.
combine that with what you saw clinically, no difference in the ARDS rate. So makes sense.
One of the things I noticed was the unreamed group got a solid nail and the reamed group got a cannulated nail. Do you think a cannulated nail versus a solid nail changes the pressure?
No, because the highest pressure when you do a reamed nail is with the first pass reamer. It doesn't matter whether it's an 8 or a 9 or a 10. Whatever you pass the first reamer with down the canal, that's your highest peak pressure.
So in terms of a critique of the paper, we kind of addressed the power analysis
Sure.
at this point. In terms of isolating chest injury patients, I know when I look at Pepe's study, he was looking specifically at those severely chest injured. I didn't see that in this study specifically, rather than
No,
just injury severity.
it was just randomized, and we thought we felt that we would capture the same amount or relatively the same amount of both groups, which we seemed to do that, but we didn't actually say further secondary randomize and do okay chest injured patient now randomize those. We didn't do that. Now as it turned out, they seem to be about the same in both groups anyway, but we didn't do that on purpose. So that would be a critique for sure if you said okay, we're going to double randomize, put them in ream versus unream, and then say okay, if they have chest injury, we're going to randomize them again to make sure those are equal in both groups. That'd be a good critique. Now, Bob O'Toole did that when he looked at resuscitation, at those things. He looked at really chest injuries and looked at, as long as you resuscitate the patient well, so the lactate was good, the ventilation parameters were good, and the patient was relatively stable, then there was no difference between their outcome and the literature in Germany. So, which is what the big comparison was as we were talking about.
So in summary, your main take home from this study in 2021.
So I think those are the take-home messages. Look at damage control as a separate event. Look at the initial event should be minimally reamed nails, and then go to the other things when you get delayed or the patient gets delayed in transfer.
Perfect. Well, I never shared my screen, but
You can share it now if you want.
I'll share it now.
Yeah.
Just so everyone can see this is the study we're referring to. And thank you, Dr. Layton, for taking the time to share your insights and thoughts on the paper.
My pleasure. Nice to see you.
All right. Do we have any questions from the question and answer section?
We do. Carolyn, go ahead if you want to.
Sure. One of the questions for the faculty was, is there any contraindication for you in nailing patients between the 4th and 10th day after the fracture event if they have a normal pH and a normal lactate? Dr. Brumback or Dr. Bone, any thoughts on that?
Hi, Bobby Brumback here. Absolutely not. When the patient's ready to be nailed, I nail them. I wouldn't, I don't use a calendar to decide best day or worst day. I know that there's been all those thoughts and things in the literature, but if they're ready to, if they're stable. Now, if they're getting worse in a pulmonary way, then Larry and I are going to have probably a discussion that brings in his expertise. But I think in general, when the patient's ready to be nailed and stable is when I fix them.
I agree with that. Can you hear me? Is my mic on?
Yeah, we can hear you.
Yes,
Okay,
we can hear you, sir.
I agree with that. I think the 48 to 72 hours, as I mentioned, is bad. But after that period, once their parameters are fine, go ahead. Now, a little bit, Bobby cautioned about if their pulmonary function is deteriorating. I'm more aggressive in that patient because I know they're already going downhill. I want to get them stabilized, the femur stabilized, so I can mobilize them. If I don't, the downhill spiral is often catastrophic. So I've taken patients that are deteriorating pulmonary wise, but otherwise stable, and fixed them and then got them up.
And that brings on the other questions inherent in the question that was asked. What was done the first 3 days?
Well, that's right.
No one's sitting around in traction now.
Yes,
So-
why weren't they done earlier? But that may have been a factor that the patient wasn't able to be stabilized to do acutely, and so they ended up having to wait.
Right. And would you consider, if someone had to wait for 3 days and was getting worse, would you consider an X fix at that point versus a nail? You know, that's I thought my thinking was that's where kind of people would be headed, and I don't think that would be wrong.
I agree.
I think they need to be stabilized.
I agree. That isn't wrong, and that's the next best option. And you know, I would have to have a specific on that one, whether I would go ahead and X fix versus definitive fixation. I just would have to see what the numbers were.
We agree.
Yes, we agree.
So can you discuss your protocol? Someone who's kind of at risk or borderline patient, what's your protocol or what's your approach as far as nailing?
My approach is, if they're borderline and I can get them out of being borderline to a stable condition, I nail them. And if I can't, I X fix them. I mean, my last JBJ article was a current concepts, and we diagrammed that all out. Pete and I did, you know, the European and the North American got together and said, okay, what can we do and what shouldn't we do? And we came down to, okay, if they're borderline and we can get them out of that situation so they're stable enough to fix, we fix them. And if they're not, then damage control and put an X fix on and see how you do.
Can we talk about specific criteria that says someone's been resuscitated or Dr. Bone re-resuscitated that tells you they're in the safe window, just for the audience? Can you hear me?
Larry?
I missed the question. Say it again.
So can we just review or criteria from the faculty as far as someone who's been resuscitated or re-resuscitated that tells you that they're ready for acute stabilization?
Well, What the ones that we don't do is because they're coagulopathic and often hypotensive because of the blood loss. And we can take that patient and give them blood and warm them up and follow their blood gases. And if they all improve over the next 6 hours, fine. This is usually the patient they get done, they become coagulopathic and hypothermic. Those patients over the next 4 to 6 hours can, if they can be stabilized to a condition that we feel is stable enough to take them to surgery and put an on them versus in fact, I've put X fixes on at the bedside in those patients in the ICU versus a definitive nail.
Dr. Brumback, what were your criteria? What are your criteria?
Well, I think is the best question because I just retired in April, so I've got to tell your audience that. Have a nice life. But I think their lactate has to be in the range. I think that we have questions about if they have increased ICP and intracranial pressures. That's a sometimes the neurosurgeon says no. Larry mentioned the coagulopathic issues and the blood replacement issues. I actually like to see their kidneys working. We see people who come in who get into an acute renal failure episode, and I'd like to see their kidneys recovering. And if they can't if they're not checking all those boxes, then I think Larry's right. You've got to put an X-fix on them and stabilize it, mobilize them. They're going to get worse if you don't. And hopefully that all happens in a relatively short time. All those decisions happen in a short time. But more importantly, the resuscitation happens in a short time and you get them back. So the number of patients that need the X-fix is, I think, relatively few. But I do think that the so-called damage control X-fix of the femur fracture has become more of a situation where we have people, not everybody comes to a trauma center where people have fixed hundreds of femurs in their life. There are people on call at community hospitals. And I think that in some situations, call has become a part where you're a sports medicine doc who doesn't really want to do a nail, but he can put on an X-fix to kind of prolong or get you to the game when you're not on call every night. I think that's also something that's happened under the heading of this damage control orthopedics. And I don't know how that may have helped a lot of patients by being stabilized early, but they do need a second operation. I realize that's not where you were headed, but you got to get the resuscitation done.
There's a question from the audience about anticoagulation. So for patients that come in anticoagulated, and I think specifically oral anticoagulants, do you allow that to delay your fixation? And if so, do you wait the 48 hours?
Larry? I think Larry may have some connection problems. I think the biggest, the 48 hours is the interesting part of your question, because now we have all this oral anticoagulation that we, of course, have no idea how anticoagulated you are. And in fact, we don't really have a very good idea how long you're anticoagulated, even though you might be able to tell them when you took your last pill. So I believe that the evidence is beginning to trickle out that it's pretty safe to operate under some of these conditions if you're doing a relatively bloodless surgery. Would it push me to do an external fixator if someone were fully anticoagulated? It probably would. But then you're going to have to go through the issue of backing off on their oral anticoagulants, possibly a vena caval filter, and then coming back when their coagulation is in fact much better. And the confusion of what's happened with all of our new anticoagulants that we can't even measure them makes your question very germane. So I think you'll find people worried about that, but I don't think I've ever nailed anybody's femur that's bled out and had massive blood loss from their thigh and so forth. I've seen pretty large thighs after injury and after nailing, but I can't say that I think that I've hurt anybody in terms of life expectancy. So a good question that I'm not sure has a scientific answer yet.
Dr. Bone, are you back on?
I am.
So the question was about nailing a femur and anticoagulation, namely oral anticoagulation. What's your take?
On a patient who's on oral anticoagulation and then comes in with a femur fracture, is that it or after the nailing?
Would you nail them while they're on oral anticoagulation?
I try to reverse them first. If I have the luxury of that, I'll reverse them first. If not, I'll nail them. Again, we have to remember the difference between the 70s and 80s and the present nailing that we're doing is as Ross said, it's a minimal reaming and a 12 nail. We're not trying to put an 18 in anymore. We don't need to.
On that discussion point of minimal reaming, 2 audience members are asking, what does minimally reaming mean to you? Dr. Layden alluded to it. What reaming styles would you describe, and what does minimal versus non-minimal reaming mean to both of you, Dr. Bone and Dr. Brumback?
I think what I would tell the residents is something that Bob Winquist, who, if you're looking into femur fractures in the literature, you got to run across his name and his work. Bob Winquist used to, when this issue came up about reaming and how big a nail you put in and is it non-reamed or not, Bob Winquist, who was always a guy who would cut to the chase, referred to the reamer as the rotating sound. And what he would do would pass a small reamer down, and when he got his first bit of chatter, he would say, I don't need to go any bigger. And he would just put a nail in, especially if they were sick. So our parameters are such, we want to get a nail in that has the larger screws in. And so whether the person has a relatively small canal and you hear reaming at 10, you're still going to put a 10 nail in it. So you got to ream it to a 11 and a half at least. You have a size in your head about the minimal size nail that you want to put in, and there's a reaming diameter that goes with that. So you don't ream above what you need to ream, in my view. I don't ream up the way we used to try to get interference fit of the nail. That it just isn't done anymore. We're just trying to get the device down them. And there are people in the world who only put in 12 nails in people of normal size. They'll go smaller if they have someone with a very tiny endosteal canal. But I look at this, the reamer is something that tells you how big a nail you should put in, or more importantly, how much you have to ream until you can get the smallest nail that you'll be happy putting in. That's the way I look at it. Larry?
And I totally agree.
All right, maybe one final topic, but it's a fairly controversial one, is bilateral femurs. What's your approach on bilateral femurs?
Larry, go ahead.
Again, it's are they stable and can they be done? And if you have a bilateral femur is a benchmark for a really high energy trauma, and they are very likely to have multiple injuries. And if they're stable and you take them enough to go to surgery and you nail the first one and they become unstable, you put a fixer on the second. And if they stay stable, you nail the second. That's our approach.
Do you do them integrated or retrograde?
It depends on the location, but if I can do them retrograde, I'd prefer to do them retrograde.
Dr. Brumback?
I would say I'm with Larry on this to a point. I have a couple of issues here. I do retrograde nailing, did a lot of it, but I tend to like antegrade nailing better in terms of maintaining length of the femur. So assuming the patient's stable enough to go to the operating room, and if they're really kind of stable but iffy, I'll do them both retrograde. On the other hand, I take the simplest femur first. Don't do the most complicated one first. One that has a fracture pattern that shows you the length and alignment of the femur when you're lining it up under image and so forth. That femur, do the easiest one first because it takes a little less time and it tells you exactly the length and diameter of the nail that you're going to need for the other side, for the more difficult side. So if you've got a simple transverse fracture on one side and a comminuted one on the other, it makes all the decisions easier on the second femur if you do the easy one first, whether it's retrograde or antegrade. I know that antegrade would require a breakdown of the entire operative field and a turning of the patient, because I do my antegrades free on a fracture table, free on a radiolucent table, I mean, so that there's more time involved. But I personally believe a comminuted femur fracture, and this has not been borne out in the literature, it's my opinion. I want to make sure everybody understands that. My opinion is I'm more accurate in length and rotation with an antegrade nailing of a comminuted, a type 4 comminution, segmental comminuted femur fracture. I'm more accurate antegrade in terms of length and rotation than I am retrograde. That's my opinion.
Any additional comments or any final thoughts? We're getting up to 8 o'clock here.
Dr. Brumback, I had a question on how did you view your relationship with your general surgery colleagues from your start time at shock trauma to when you worked all the way through there, before the end of your career? What was the evolution of the relationship like? Because Dr. Bone alluded to in his writing of his paper and ongoing. I just wondered if you could comment on that relationship or dynamic.
Michael, it was very positive. I felt like I was part of a team. I did not feel like I was needing to be a puffy-chested adversary to my general surgery colleagues. I did not meet a lot of resistance in terms of what Larry discussed in his video for his paper about it's time to move along. They accepted the issue of us doing things quickly, and we did them in the middle of the night. I mean, we nailed the femurs as they came in. I can't tell you how many times I left my house at 2 o'clock in the morning to nail a femur back then. And now it's totally different. Now we're nailing them early, but we're not nailing them that early. We're not nailing them in the single digit AM hours. We're at maybe 9, 10, 11, but we're not doing it at 3, 4, and 5. I think that I had, in general, very good support from the institution and my general surgery colleagues. And I think we were very sheltered from the pressures of being in a community hospital and having other people have other jobs and other practices. This was our only thing that we did. And I think that's probably what made it work. We're all pulling the wagon in the same direction, and it was very important for that to be true. Whereas I don't know that that's true now, that there's so many people taking trauma call and trauma patients being delivered to so many different hospitals. That's the difference that occurred, is that community hospitals have trauma surgeons and they are doing trauma. And I'm not saying that's bad. I'm just saying it's different. I'm thrilled to have known my orthopedic colleagues academically, like Ross and Larry, who people I know and could have called today and ask a question of, and they would have answered the phone, just like I would have for them. But my general surgery colleagues were the same way. So I had good experiences with them.
Thank you.
And then I just had a kind of a final question. I guess, at this point, where do we go from here? What, in your opinion, are relevant study questions going forward?
I have one question, and that I know some of my colleagues are only using second generation or cephalomedullary nailings for midshaft femur fractures, and the piriformis fossa has kind of gotten out of vogue. I wonder whether or not those nailings are the same. And my concerns may be that there may be a little bit more malalignment with the cephalomedullary nail than a piriformis nail, but does it matter in the function of the patients? And so the study that needs to be looked at is a randomized study of piriformis nailing of shafts versus cephalomedullary nailing of shafts, and then, or shall I say, greater trochanteric starting portal, not necessarily cephalomedullary, but, and then look at the alignment, you measure it, and then see if it makes any difference in their final function. I think we're getting down to patient function questions at this point.
From the polytrauma standpoint, and I don't know if we have the wherewithal to study this yet, but there may be a genetic component to certain patients that no matter what you do to them, they're gonna go downhill. And we've seen every now and then you do the right thing and a patient still dies, and why? And so, but there may be something in their genetic makeup. And if we can find that, then perhaps we can determine how best to treat them in the future.
Well, I'd like to thank Dr. Brumback and Dr. Bone for hanging with us tonight. And we've got a couple more slides here and then we'll wrap it up. So any last take-home messages?
Nail
Resuscitate them.
Resuscitate and nail.
We didn't talk enough about the resuscitation early and well. That makes the difference. And I think that was the difference between North America and Europe.
Early aggressive resuscitation and
Early aggressive resuscitation.
okay. All right, upcoming journal clubs are next month. Liz Frank in December, damage control versus early total care, and then January is non-unions. And I'd like to thank Dr. Brumback and Dr. Bone again for joining us and providing their insight. Thank you very much. And you can see the recordings on YouTube, and there will be it'll be available 24 hours after this session is over.